Now it's my pleasure to invite Dr. Kasturi. Dr. Kasturi is the current president of Asia Pacific Society of Reconstructive and Plastic Surgery. So I think it's indeed a matter of great honor for us to be here sitting with one past president of Asia Pacific Society and one current president of Asia Pacific Society of Reconstructive and Oculoplastic Surgery. She is an excellent teacher and a very, one can say, a thorough oculoplastic surgeon. We always tend to learn things from her presentations, at least me. So we look forward for your talk, Dr. Kasturi.
Thank you, Dr. Mukesh, for having me in the course and also for the kind words. You let me know when to stop. I'll just, because it's a very basic course, I'd like to go slow.
We'll have to do 8-minute talk only.
Yeah. Yeah, once it is 8, so no financial disclosure. So whenever we think of doing blepharoplasty, especially for the upper lids, we should know some difference between the Asian and the non-Asian eyelid. Definitely in terms of the lid crease, where we see the non-Asian, like Indians have a much beautiful lid crease as compared to the Asian eyelids. Then the tarsal plate height. The tarsal plate height for the Asian, that is especially for those from the Southeast Asian countries, it is much smaller as compared to the Asian height, tarsal height. And the third difference we see, the fat is more in the Asian eyelid as compared to the Indian or to the non-Asian eyelid. Then there is always an epicanthal fold in most of the Asian eyelid. And the most important, if you look to the skin texture, you will find that the skin of the Asian eyelids are much thicker as compared to the non-Asian. So considering all these important points, we should plan how do we go ahead for the blepharoplasty. And for the upper lid, it is a small, very simple surgery where variable amount of the eyelid skin, the orbicularis oculi muscle and the orbital fat, these are being either excised or retrieved or sculpted in order to bring a very rejuvenated eyelid. So this word blepharoplasty has come from the word blepharon, which itself means the eyelids, and the plasticos means to mold. Today it is one of the most time-tested surgery, having both functional and cosmetic indication. Functional because I have already mentioned that the Asian eyelids we have the lateral ptosis, lash ptosis. Because of the lash ptosis, it keeps on touching the cornea, and this causes the release of all the inflammatory mediators, especially the MMP9 and other cytokines, and this inflammation leads to the increased osmolarity, and then the tear production decreases. So this vicious cycle keeps on going. So this is a very common indication why we prefer doing a upper lid blepharoplasty, and which has already been reported by us. And this is where you can see the eyelashes being redirected, as you can see this before and after the procedure. So this is what I have seen, especially in the northeastern part of India. This creation of this lid fold, lid crease, along with the redirection of the eyelashes really helps him to prevent many of the corneal complication. Second important indication is aesthetic. Aesthetic, where we want to have a beautiful lid crease with a good tarsal plate height. So when I talk of blepharoplasty, there are different ways of doing upper. It can be a mini, it can be standard, it can be only muscle excision or extended blepharoplasty, or can be a skin excision with or without fat redripping. And all of these depends on the type of the surgery, how much amount the skin, muscle or the fat are being excised. So mini is something which is very nice to be done, which is something like MMCR for ptosis surgery, where you just need to give small 2 incision, expose the LPS after incising the orbital septum, and then you need to give the sutures. This is how we do a mini blepharoplasty. Like you can see, there's asymmetry, and she has a very small, the lid crease. So you give 2-step incision, then you expose the orbital septum, incise the orbital septum, and you should be sure that you have incised, take out some of the post-septal fat, and then you put a suture, skin, orbicularis, LPS, skin, orbicularis, skin. So there are different ways. If you take a bite in the tarsus, you will give a very static crease. But if you just take the bite of the aponeurosis, the chance of static crease is not there, and it gives a much natural dynamic crease. So this is what we want, especially in the small children, small girls, where the only indication is to have a small beautiful lid crease, and this is one of the most common indication of surgery, and they feel so good. Like this is one of the doctor for whom I have done, and the next day or after a few days she had sent this, then ma'am, I feel that this lid surgery has boosted my confidence. So this is what a small surgery can really bring about a big change. But what is a standard blepharoplasty? Here you need to excise some amount of the skin or muscle and the fat, depending upon how much amount of the fat distribution is in the upper lip. So this is just after the skin excision, then you can see the orbicular is being excised, then you incise the orbital septum, and then you can see the two fat pad, the medial and the central. So upper lid, we know there are two fat pad, and you decide how much amount of this fat you want to remove, or you don't want to remove, or you want to go for redraping, and then you go for lid crease formation. Here I am going for static formation because I am taking a bite on this on the tarsus, and this is what exactly you can see. This, and the crease is so very prominent and it is so static, and this is basically required by the Indian people who do not have the lid crease, and not in the other Southeast Asian country, where they, which I call the Indian blepharoplasty or Bharatiya blepharoplasty, whatever you see, because they want a good lid crease, they want a static lid crease, and not even then they want a good tarsal plate height, so that the, even if you apply the eye makeup, it is seen much better. So now what we see that today nowadays there are multiple cases of blepharospasm, and especially for the apex of the lid opening. In such situation, it is what we call a muscle blepharoplasty, where you need to remove most of the protectors of the lid. And when I say of the protectors of the lid, it not only includes the orbicularis, it includes the corrugator, it also includes the procedures. So after removing very small amount of the skin, it is mainly concentrated to the orbicularis excision along with some parts of the corrugator and the procedures. You need to go up to the fronto-orbicularis interdigitation, and then you should be very sure that you are actually removing the corrugators, and but you have to be very careful. Just below the corrugator we have the superior ophthalmic vein. So you should see and excise. Can you see? This is a superior ophthalmic vein. So you should see and excise, and then once you excise, I am going little fast. Go for the same procedure in the lower lid, and this is how you have excised most of the patient, most of the muscle, and what you can see, the patients really feel that the quality of life is improved. As you can see, this lady, you can see how she was before the operation, and this is after. Sometimes you need to give Botox also only to the frontal part but not to the other part, and she feels that what she has mentioned, that she feels that now she is a much better woman or a new woman. But what I mean to say that along with this, whatever tissue you excise, you need to have the eyebrow in the correct position. So always do a eyebrow fixation, which can be an internal bropexy, and this is the traditional way of internal bropexy. But what I believe nowadays, that to have a more permanent result, I do something which we'll do for a scleral fixated IOL surgery, like the 4-point fixation. So what is this? This I call, this is one of the innovative way that I have started, which is I call the guiding technique. So I take a 4 of Prolene suture and I make 2 fixation on the either side, making a 4 fixation. You don't need to take the suture out, you just glide it along the roof and also the suborbicularis tissue, and then you fix it to the periosteum. Go just below the periosteum and then you fix it there. So this is a very nice way of doing a internal fixation. Sometimes you have patient like this where you need to do more extent with blepharoplasty, where along with the removing of the skin, removing of the muscle, what you need to remove is that you need to remove even the roof. So this is a roof that I have removed, and once you remove the roof, the same thing, you have to keep the eyebrow in the correct position. That is the refixation of the eyebrow, and you can see that it really helps them functionally. How it helps them? By increasing the temporal field of vision, by
Dr.
also
Kasturi, please
decreasing
sum up.
the astigmatism and also the high order aberration. So with this I would like to conclude. Thank you very much.